In this episode, our guest is Dr. David Veale. He's here to discuss treatment-resistant OCD. Dr. Veale is consultant psychiatrist in cognitive behavior therapy at the South London and Maudsley NHS Trust and the Priory Hospital, North London. He specializes in obsessive-compulsive disorder, body dysmorphic disorder, health anxiety, depression, and emetophobia. His group published a paper in BMC Psychiatry called Atypical Antipsychotic Augmentation in SSRI Treatment Refractory Obsessive-Compulsive Disorder, a systematic review and meta-analysis. Treatment of obsessive-compulsive disorder is often challenging. Treatment resistance is quite common. Between 40 to 60% of patients don't show an adequate response to first-line treatments. There's an additional problem. Currently, we don't have a standard definition of treatment resistance. So I asked Dr. Veale about a practical definition for clinicians.
Well, research has used various criteria in terms of the percentage reduction on standardized scales like the Yale-Brown Obsessive-Compulsive Scale. But for clinicians, I think it's primarily about whether your patient remains significantly distressed or handicapped, interfered in their life by the symptoms of OCD. So I think it's just quite, they still have OCD.
Now, our guest describes a stepped approach for treating OCD. This includes how to use SSRIs, the role of clomipramine, a stepped approach also for CBT, and when to use antipsychotics. He discusses the findings of his meta-analysis.
In general, we'd use a stepped approach in medication. And so, as you say, you start off with one SSRI. And the problem is that people don't necessarily use it at the maximum tolerated dose for at least 3 or 4 months. Because, there is this dose-response relationship. And unless you get up to the highest tolerated dose for at least 3 months, then you can't really say whether you've not had any benefit from it or anything. Yeah. Now, it's true that sometimes people can't tolerate higher doses, but that's the thing to aim for. And as you say, if that doesn't work, you'd go on to an alternative SSRI. Again, maximum tolerated dose for at least 3 months. Then you might want to consider clomipramine. Again, as you know, a little bit more difficult to use because you're more likely to get side effects in the higher doses and so on. But certainly 2 SSRIs and clomipramine would be the sort of pharmacological stepped approach. And it often depends upon, obviously, the availability of CBT. But, CBT is also done in a stepped approach because if you get more intensive CBT, then it may be a more experienced therapist or more frequent sessions and so on. So, both of those can go together. The question is then what you do if, you're still distressed and handicapped. And that's when the antipsychotics come in. And so you'd be staying on the maximum tolerated SSRI. And the meta-analysis found that mainly it's best to use probably aripiprazole or risperidone. Aripiprazole and risperidone are probably the most effective in OCD, or at least that's what the meta-analysis shows. But the key issue is that it's not like using an antipsychotics for schizophrenia or something, and that you can use quite low doses. So some of the trials found risperidone at even 0.5 milligrams was effective, and so equivalent of aripiprazole might be 2.5 or 5 milligrams. So you can use quite low doses, and furthermore, you can find out whether it's been effective or not within 4 weeks. So that, if it really has had no benefit in 4 weeks at a low dose, well, possibly some people might increase the dose, but, it's probably very unlikely to have any further benefit. And you might well then want to discontinue it. It's not something that you just want to leave someone on for many months and years, like, something you would be perhaps with an antipsychotic in schizophrenia. If it's not working, there's no point in staying on it, really.
What if it works?
Then you would probably want to stay on it. But what we don't know is actually all these studies so far have only been done for 3 months or so. And no one's actually done any good studies in the long term. There's a small study that suggests if you are getting benefit and then you stop taking it, then you're more likely to relapse. But, there's one long-term study going on at the moment in Japan on aripiprazole, and I think that's going to be we'll look forward to that because people want to know how effective it is in the long term. Does the effect wear off over time or anything? We just don't know. But the key issue is that, low doses for at least a month, and then you can decide whether to remain on it or not.
Is there a symptom profile useful to identify those patients that might show response to antipsychotics?
People have looked at this, and one or two trials said first of all that people with comorbid tics, but then that didn't come out in other trials, and perhaps sometimes certain types of symptoms. It may be if you're highly anxious or something, it might just help to reduce your level of arousal, but there's no good evidence really at all. No one knows. It's just a matter of trial and error, to be honest.
What other options do we have for treatment-resistant OCD?
The only other thing to say is that there is some evidence, like one or two isolated trials from mega doses of SSRIs, that very high levels of SSRIs, but you would need to do ECG monitoring and serum monitoring of the particular drug. If you're going to go up to sertraline 400 or fluoxetine 120 or 60 or something. So that these are done sometimes because there are some people who are maybe quite rapid metabolizers and things like that. So occasionally that might be worth investigating. Mm-hmm. And there are one or two trials done on lamotrigine. That has been adding to an SSRI, and a trial on memantine adding to an SSRI. So there is a sort of scraping the barrel to certain types of medications at the bottom of the barrel, but it's tough, and probably there is a group of patients who really struggle with all medications and the CBT as well. And certainly at our own unit, we have such patients are in our residential unit, like an inpatient unit, and they get intensive therapy. So that you're getting CBT 3-4 times a week with an assistant therapist, and it's the right environment in terms of support and so on. So if that doesn't work, then there is experimental work going on in terms of looking at deep brain stimulation. So there's always something around the corner.
That was Dr. David Veale on treatment-resistant OCD. For more psychopharmacology updates, visit psychopharmacologyinstitute.com.